Dr. Sanborn attended the University of Tennessee, Memphis, where he received his medical degree and completed his residency in general surgery at Madigan Army Medical Center. Dr. Sanborn is part of the Erlanger Metabolic and Bariatric Surgery Center and is board certified by the American Board of Surgery. Dr. Sanborn is devoted to ensuring the longevity of his patients' health and developing long-lasting relationships with them. He takes his time to understand symptoms and give correct diagnoses to ensure the continued health of all of his patients. Thank you for speaking to us today.
All right, thank you. I talked to Lou Lambiasi last week, and I'm not sure who was going to speak originally, but I do appreciate the opportunity. So with 1 week's notice, you don't get pithy titles. So we'll just talk about concepts in obesity. I did come up with one. I was going to say we could talk about the big O, but I was told that was already taken, and might be bad form to use that one, so we didn't use that. On conflicts, I used to be a proctor for Intuitive, but I haven't done that in quite a while, and I don't think I'm on the rolls anymore, so I don't have any conflicts. There's a couple quotes that I found that were really great when you concern the topic of obesity, and this was one: for every complex problem, there's a solution that is simple, neat, and wrong. And we seem to keep going through a lot of that when it comes to treating obesity, and I think we'll continue to go through that for a little bit. And I don't know if anybody's Usual Suspects fans out there, probably not Kevin Spacey fans anymore, but at least back in the good days when we all thought he was a good actor, there's a great quote: "The greatest trick the devil ever pulled was convincing the world he didn't exist." And, you know, I think you can make this analogous to obesity. The biggest problem we have with obesity is recognizing it as a disease process. Okay, we can get into semantics. Is it a disease? Is it a marker of disease? And those kind of things. But we don't all uniformly treat it as a disease, and that's kind of the problem. So until we can do that, until we can recognize that it exists, then we're going to have problems. So kind of along those lines, you know, back in 2013, I don't know if you remember, the AMA came out that year and said, okay, obesity is a problem. In fact, it's a disease. It meets our criteria for disease. And this was one of the responses there, and I don't know Jeff Edelstein, and he may be a great guy. And I think his response was very characteristic of a lot of people at the time, including doctors, okay, that, you know, basically this is just eating too much and exercising too little. And he's here talking about too many big backs and too few jumping jacks. And if it's just that, then the eating less and exercising more would work. It'd be foolproof, just like he's saying. And I really like his middle statement there, that he's not spouting anything any other idiot could just as easily spout. That's right, Jeff. You're not, right? Any idiot can say that, right? But we're smarter than that, and so we're learning, and we're finding other things that we can do. So kind of at the same time, and even since then, the argument kind of rages on. Is it a disease? You know, and quite honestly, I don't care if it's a disease or a marker disease or a condition that's caused by another set of diseases. We address it the same, really, or we should, as any other disease. So on the pro side, they said it meets criteria. It's an impairment of function. It's got characteristic signs and symptoms, and it causes morbidity. Fair enough. Okay, decreases lifespan. It's just like every other disease we talk about treating pretty much. It can be genetics. It's got a lot of different causes. Okay, the next one's kind of so-so. Recognized by multiple government and professional organizations. That includes our own organizations now. Very few haven't come out recognizing obesity as a disease now. But again, that's just the official recognition of that. Historically recognized before, even back as 17th century, see references to corpulence and things like that. Now, on the con side, it's a preventable risk factor. It's not a disease. Okay, side effects of a disease, but it's not a disease itself. And then there's the people who are healthy obese. So about a third of the obese people don't have metabolic syndromes. That's fine. Ask them how the joints feel, right? I mean, so it's kind of hard to define that healthy obesity as being truly healthy if you're only looking at a subset of the diseases that are associated with it. It's a result of eating too much and also a result of sedentary lifestyle. Well, we have a lot of evidence now that shows it's not simple as that. And then making obesity a disease means a third of Americans are sick. All the horror, right? I mean, how many people have heart disease? So if we hadn't recognized that as a disease, and all of a sudden we say, okay, that's a disease, how many people would that have made sick? Probably about half the country, right? So, you know, just because we've now recognized that there's an illness doesn't really perturb us from trying to treat it. But if obesity is merely a disease of lifestyle issues and choice and poor eating habits and lack of exercise, and those are contributors to the disease, what about all these other ones that we treat all the time? All right? I mean, they all have those components to them. And you can layer on the same lifestyle interventions before you get the medications and surgeries and other treatments with those. So what is the difference when we look at obesity and these other diseases? And I would submit that it is simply that, the appearance, because we can see the obesity. We don't see the heart disease. We don't see the high blood pressure necessarily. Now, there are some other subtle signs and symptoms, I mean, we can see, but this is very obvious when somebody comes in that they have some problem with obesity. We don't know why that is the way it is. And don't feel bad. This is a model that is actually approved for uses like this. I don't want anybody thinking I'm embarrassing somebody. And this is actually put up by the Obesity Action Coalition. I chose this particular one out of the 140 slides I had because, boy, he's looking pretty judgmental at people judging him on his appearance, right? So if we look at obesity and just try to distinguish some degrees of obesity, and this is kind of where we start getting into areas that I don't really like because we start defining things by weights and just BMIs, and it is a little too simple, I admit that, but it is what we have, and it's reproducible, and we can follow it. But if you look here, we've got our normal weight individual over here, which I would say if you were just looking at these, you might even pick this one out as looking a little bit thin. Our overweight individual here. So overweight's basically BMI over 25. Over 30, we get into obesity, and 35 and 40, severe obesity or morbid obesity if it's got other related conditions or if it's 40 or more in and of itself. I would defy you to find anybody from obesity on or even severe obesity on is really not starting to collect other medical problems. Okay, so, I mean, you could make the argument once you get there, it's pretty much all morbid. I mean, there's some morbidity that's going on with it. Okay, there are some pitfalls with it, of course. Muscle excess. A classic example of this is Arnold Schwarzenegger. You know, he was Mr. Olympia. BMI was 31. Well, 31 would have been obese, right? Well, obviously not. All right, there's some ethnic variations. We go to Korea, we'll start seeing type 2 diabetes at a BMI maybe 26. Okay, so at a lower BMI. There's a little bit of relative sarcopenia, so we see some differences there. And then as we age, okay, we lose a little bit of height. That affects our BMI calculation. We start falsely elevating the BMI. But this is the great thing. Okay, we're all professionals. Okay, most of us in here, I guess, we're doctors. All right, so we can make judgments. All right, so the BMI is a good guide. And even if you got somebody who's not morbidly obese, who's not obese, maybe not even overweight, you can still follow the BMI as you follow them as a patient, and that will give you some indications of what's going on, at least weight-wise. So what's the problem with obesity other than just carrying extra fat? Okay, well, basically every organ system in the body is affected by it. Okay, whether it's heart disease, just high blood pressure, high cholesterol, all those markers for heart disease, those are the ones we worry about a lot. Gallbladder disease, the gallstones. Most patients I actually see in the clinic that come see me for surgery have already had their gallbladders taken out. So it's a pretty tight relationship there. The sleep apnea. Okay, so there's a lot of different things, even cancer. So I won't go through them all because there's literally hundreds of them, but you guys know the big ones already. And then the other problem is if you look at all-cause mortality, okay, the relative risk of death is correlated to the body mass index. And so this is kind of a classic chart that is used here, and I will tell you a lot of people shorten up this axis down here to make that look even steeper. Okay, but you can see the point here as you get out to BMI of about 35, you're already 1.5, almost 2 times risk, and then as you get 40 and above, you're up to 3 times risk. Now, if you ever use this to show a patient that, boy, you know, your risk of death goes up with your weight, so this is really important, you know, you should remind them that the overall risk of death is going to be a really low number. So even though you talk about 2 times the risk or 3 times the risk, that's times a very small number. So it's still small. It's not, they're not going to die when they walk out of there if they don't lose 50 pounds before they leave your clinic, right? Okay, so we got to keep it in perspective. But it does show the power of that increasing body mass index. And then there's the effects on the individual themselves, the depression and anxiety that goes along with that, the self-esteem issues, low educational attainments, lower employment status, lower salary. They're less likely to marry, and if they do, they're more likely to divorce, and a higher suicide rate. Okay, so it's not a fun life dealing with this disease either. And then, aside from the individual, there's a problem with the effects on everybody, economically. I mean, you can see the numbers there, the medical care costs, and this is actually from a few years ago, so it's probably even higher now. But we even look down here, for people like me that were in the Army before, we look at this and we think our military readiness. So we've decreased the applicant pool, basically, that we can select from because people can't make it in according to the standards that we have. And we can argue about relaxing standards and things like that, but the fact is we're not able to employ those in our military right now. So taking everything together, about 5% of our GDP, so it's a pretty big impact on the system. So ultimately, we look at a disease that comes down to dysregulation of our weight and energy balance. And so I will tell you that typically we do very well with the weight and energy balance, the food intake and the energy expenditures and balancing that. Body's set up with a great system. In fact, a great example here is basically looking at the energy intake over the course of a year. There's only about a 0.4% error, okay, that can lead to a pound in a year. Okay, so it's about 11 calories a day, so for anybody who likes your Pringles or anything like that, it's maybe 1 or 2 of those. Okay, and that's regulation that's done on a hormonal level, and that's done on a physiologic level, because there's very few people that can know when they've eaten that 1 or 2 extra potato chips, right? And you say, well, stop, I might gain weight if I do that. All right, now, this is a subtle example, but it's a very real example, because if you look at the course of a year, 1 pound, and most people, okay, that's 1 pound. I mean, what difference does that make? Okay, that's 1 year in their life. What if they've been doing that consistently for 10 or 20 years? That's 10 or 20 pounds overweight. Okay, but let's take a different example and do about maybe 100 extra calories a day rather than just 10. 100 is still pretty subtle, and it's still very healthy. I mean, you get a decent-sized apple, you get 100. I mean, that seems pretty healthy, right? Every healthy pack out there is packaged in 100-calorie packs. Right, so you can get a lot of seemingly healthy things, but 100 extra calories a day over the course of years is going to be about 10 or 11 pounds. Okay, 10 or 11 pounds over the course of 10 to 20 years, you compound that, and that's a lot of extra weight. Right, so it can be very subtle that can lead to these, a very big degree of obesity. The good news for you is I'm not going through everything on this slide. I just throw this out there because I want you to see that it is a very complex process. Okay, and this is a very simplified graph of this. All right, and the other interesting things I always like to point out to people, and you guys probably know this already now, is fat. It's not just fat. It's not just storing fat. It's not releasing it when we need it. It's not releasing when we lose weight. It is making hormones that regulate itself. Okay, I'm not sure, they don't do a good job here, but there should be some arrows going through some muscle as well. Muscle also helps regulate our energy storage and our fat mass. So there's a lot involved in it, and we'll talk a little bit about some of the gut hormones a little bit later, and we'll touch on that. But just suffice to say, there's a lot involved in it. And all this goes to defending basically a set point for fat storage. And when I talk to my patients, I talk to them as a set point is almost being like a thermostat for weight. Okay, and it's almost like an evil thermostat that seems very easy to turn up but very hard to turn down. And that seems to be, maybe that's evolutionary. That's why it was that way, because obviously there was some benefit to eating more, okay, but not a lot to make us eat less. Although I will tell you, the set point works both ways. It is very hard to intentionally gain weight. Okay, if you're not wired that way, it's hard to actually pack that weight on. Okay, Dr. Kaplan has worked with other people, and he come talk to us before. He talks about the people, the actors, and people that have gained weight for roles in movies. That's really hard for them to get that weight on. Okay, of course, they'll talk about how easy it is to take the weight off afterwards because they just quit overeating, but they have consciously done that. But what we have here is a balance between the energy intake and the energy expenditure, and that sets us at a set point. So if we eat more, we will expend more energy, and that will bring us back to the set point. If we eat less, and you know this if you've ever been on a diet or your patients have been on a diet, what happens to their energy levels? It drops. And so that's to bring things back to the set point and try to keep things at what the body does is homeostasis, right? Bring it back to the same. So we have this continual balance for the set point of the body when it comes to energy storage. And there's a lot of different things involved in that. few of these are down here, and we look at what's going on different now, why we have more problems with this now, why we have an altered food supply. Okay, so it is not just whole natural foods. We have enriched foods. We have foods out there that drive our appetite for more of the same. Okay, so the food supply has been altered. We can get into talking about, antibiotics that are used in the production of food and different things like that and how they affect us. Stress will affect it, and everybody's going to have different levels of that. Medications are thought to be a very big player in creating the obesity problem. And there's a lot of medications we see that do that. I know that, every now and then I'll have a patient that comes in and they have gained a significant amount of weight. They've had the surgery done well, gained a significant amount of weight, and, I kind of go through things with them. It's kind of hard. There's a lot of shoulder shrugging on what's going on. We come up with a plan, and, I may be the only one, but finally, by the time they're about to leave, I look at the medication list, and I see Zyprexa on there. It's like, okay, well, there you go. That's good for about 60 or 70 pounds. All right, so there are some that are more so than others, but that's certainly a big one. Unhealthy muscle or the lack of exercise, and then impaired circadian rhythms. So this is one reason why we push a lot of our patients to go get their sleep apnea studies and everything. If they are not sleeping at night and getting good quality sleep, they're wanting to sleep during the daytime, and it's hard for them to stay engaged during the daytime. And all of these gut hormones and everything, they have circadian rhythms as well, and so it affects their output. And then on the other side, we have voluntary control and then whatever treatments that we can throw at them. And, of course, really of trying to dial back these things to all try to affect that set point. So binge eating disorder. All right, this is one I like to bring up here as one that is very hard. And any psychologists in the room, by the way? Okay. I don't want to offend any psychologists, but when we look at things like this, the binge eating disorder, a lot of these things are diagnosed or they're written on understandings of obesity that I think, well before what we know now, and don't take into account a lot of these things. And I'm not saying that binge eating disorder is not a thing. I'm sure it is for probably a lot of people. But if we start looking at the criteria for it and we just dissect what's really going on with the patient, it does get a little bit more interesting. So if we can look at the criteria here, we've got consuming abnormally a large amount of food in a short period of time compared to what others might eat in the same time period. And a lot of times this is stated as what a reasonable person would do, okay? Experiencing a loss of control over that, so they'll feel like they're controlled. And then, of course, they consume faster than early. They consume until they're uncomfortably full. Large amounts, maybe when they're not hungry. You only have to have a few of these. Food alone due to embarrassment, and then they feel disgust, depressed, or guilty after the binge, okay? So why don't you just take a patient who's on a diet and see what happens to them, okay? So they have been really good. Let's say this patient's been really good during the day, and they may have had 150 calories or so in whatever little shake they had that morning, and then at lunchtime maybe they did the same thing or had a little salad, and they've kept everything going. But what happens if anybody here has been on a diet before? You know what happens. What happens about 4 or 5 o'clock? Well, the wheels fall off on that diet a lot of times because you're really hungry because you have basically starved yourself all day. And you have a lot of mechanisms in the body that are geared to push you back to that set point to get those calories in. So then you have from whatever time you got home till whatever time you go to bed to get the balance of those calories in. To get the balance of those calories in, it's going to require you to probably eat more than what a reasonable person would eat and probably eat it fairly quick in that time. And you can probably at least meet criteria down here too, because you've eaten faster than normal. You might feel uncomfortably full, and you're probably going to feel bad or guilty about it because you're on a diet and you just blew it, right? And if anybody's been on a diet, you know this can happen again and again and again. So, to say they're binge eating, I could easily point to that patient and say, no, physiology is actually working for that patient. It may not be working in their favor, but that's what's going on. So it can get really hard to tease out a lot of the psychological stuff from the physiologic stuff, and, of course, there's drivers in both directions. This was adapted from one of Dr. Kaplan's past lectures, and the main point of this is each of these bars here will represent an individual, and they have a set point somewhere along the BMI, and then they can affect it one way or the other voluntarily, meaning you can starve yourself or you can eat in excess and push it only so far. some are pretty narrowly defined, and some have a pretty wide range, but they're all different, and that's because we're all wired different because we have different genes, and those genes encode for those hormones, and so everything's going to be just a little bit different between us. So the current theory, the basis of obesity, is that the physiology of energy balance drives the behavior rather than what was typically thought is the behavior drives the physiology of energy balance. So if you want to sum it up in those terms, it is, people aren't obese because they eat too much. They eat too much because they have the disease of obesity. Okay, so if we get to separate out that physiology and the behavior, and when we see what we see and we see the behavior we see, know that there is a driver for that. Okay. And so we can see some of this variation here. This is variation in response to different diets. And you can see the distributions here. Some people do well, some people don't. And what you want to do is try to pick the ones where they actually are doing well and do more of that. Problem is it's going to be different for everybody. And when we talk about having different genes, so this is all based on a couple nucleotide change here in a single gene and the response to the same diet with these people. And they all have a different response based on that one gene. Okay? And this is one that I'm sure everybody works with every day, fibroblast growth factor 21. It's involved in energy balance. Okay? I can't tell you more than that about it, but I can tell you by basically altering a couple of nucleotides in it, I can change somebody's response to diet. And that's just an example of probably what is going to be 1,000 or more different genes that are actually involved in the overall energy balance equation. We can also see variation in responses to therapy. Okay, we have diet here, so some people do lose some weight here. They've done a low-carb diet here. We've actually had low-agrotide here, and we actually see pretty good results. I always cringe a little bit. When Dr. Kaplan will look at slides like this, he will point out that we have people here that overlap with some of our gastric bypass patients. Okay, so we can actually get some very good. It's not as many, but this is why it's worth trying some of these medications, because we've got some people that will do very well with those. This is a duodenal lining here. This is almost like a windsock for the duodenum. It was in trials a few years ago. I think they finally got them back in trials now again. They had some liver abscess problems, but they're seeing pretty good weight loss with those as well. Okay, so we don't see uniform responses. We just don't have that, but we have to look for those opportunities. So there is a dose of realism that we know that there's no 100% treatment for this. Okay, and that's hard for me as a surgeon sometimes, because for most part, we have other diseases where I can operate, and I know 100% that appendix is not coming back again, right? That gallbladder most likely is not going to cause issues again, okay? At least the gallbladder won't, right? But here, we may have a continual fight. We do know that diet and exercise aren't enough, so we have to expand the armamentarium past that. Most medical therapies, unfortunately right now, have fairly modest results. And the other problem, and this is the biggest problem I think with the medications, is they take too long to work. Okay, and that's not necessarily a problem, for us or the medication. It's a problem for the patients, because the patients have been trained, come see us and you're going to lose 30 pounds in the first month, right? And that you're guaranteed to lose this if you follow our directions and all those kind of things. So when they lose 2 pounds that month, they have trouble seeing that if they lose 2 pounds every month for the year, they're going to have 24 pounds off, and that'll actually make a palpable weight loss for them. But they have trouble seeing that at that time. Okay, so if you don't have a big weight loss, you'll produce a big weight loss fairly quickly. It's going to be hard to keep their faith in what they're doing. And then when we get down here, we can't operate ourselves out of the problem. We've always talked about there's less than 1% of the patients that would be eligible for an operation for weight loss to treat their obesity. But with all the bariatric surgeons we have now, if we recruited our general surgeons, we could not take care of all the patients. We can't scale this out to take care of everything. So we have to go back and look at our diet and exercise and our medical therapies and maximize those as well if we want to get to as many people as we can. So also with those realistic expectations, we have to look back down and talk to the patients about benefits of more modest weight loss as well, okay, because we don't always have to achieve a huge weight loss to actually get some benefits. And I'm sure you guys have already seen a lot of these reductions and everything from just a 5 or 10% weight loss. And I will tell you that it's very interesting looking at the world of medications and how they roll out and how things change. Is I always remember talking about the benefits of a 10% weight loss. And then something happened probably about 5 years ago now, I think, that we started talking about 5% weight loss. And I really kind of saw that kind of correlate with one of the medications that came out and had an average of about 5%. Okay, so I'm not saying, I'm just saying that some things change sometimes based on what you can get. And but there are advantages to even the modest weight loss, so it's all worth going for, especially if you can find some low-hanging fruit to help out with it. A lot of different things. A lot of people think there's not much that we can do, but when you look at all the different lifestyle changes, all the different diets out there and everything, combine those with medications. Again, all these aren't mutually exclusive. You can use one or more in combination, and then if you combine that with medical devices, endoscopic therapies, and surgical therapies, I mean, I can't even calculate the permutations up here for you, but there's a lot, right? Thousands of combinations there. So, because I'm a surgeon, we'll talk about surgery for just a little bit and kind of give you kind of an update on what the landscape of that looks like. Primarily, what people will talk about now will still be gastric bypass and gastric sleeves. Duodenal switch is kind of always rumbling around in there of a few percent being done, and there's a lot of excitement about maybe some more of those being done, but it's not quite there yet. And bands seem to be pretty much well on their way out at this point. How we're doing the surgeries hasn't really changed in the last 10 years or so. It is almost all laparoscopic and robotic. Robotic is pretty much just think of it as laparoscopic because from the patient point of view, there's really not much difference unless maybe you're a reoperative patient and the robot might offer some real advantages there. From the surgeon point of view and the surgeon's shoulders and neck and everything like that, robotic is clearly superior, but otherwise they're both just laparoscopic surgeries. There are some newer surgeries out there. You'll hear about them, and you'll see them advertised. The single anastomosis surgeries, whether it's a duodenal switch, they come up with some fancy names here, stomach intestinal pylorus sparing surgery, the SIPS, which is a single anastomosis duodenal switch, okay, and then the single anastomosis RNY Gastric Bypass, also known as the mini gastric bypass or the omega loop gastric bypass, and you'll see those out there as well. And there's a lot of trials going on to see if these are comparable to the traditional way of doing those. Vagus nerve blocking came out and quickly fell away. It's not commercially available right now, although I'll show you what that was about, because maybe it'll come back at some time. They just couldn't make it affordable. Gastric balloons, kind of a mini rage until you look at the results and see how they're doing and have to manage the patients, and then the enthusiasm gets tempered a little bit. Interluminal sleeves is something that's being looked at now. I won't get into that too much today because that is still pretty much truly experimental. And then gastric venting, if anybody's ever seen the Aspire Assist device, we won't talk about that maybe quite as much, but it is an FDA-approved device. It's like a big, giant gastric tube that they suck their meals out after they eat. And so not the most appetizing thing to talk about, but there is some effectiveness there, but it has very, very limited enthusiasm, as you might suspect. So what are the mechanisms by how surgery works? Traditionally, it was thought to be restrictive and malabsorptive. So, restrictive is just limiting how much food you can eat. And I love doing this with our patients. Like, what's the easiest way I can restrict you from eating? And somebody will usually come over that you can wire our jaw shut. Okay, well, okay, sounds funny, but it has been done, and it's still offered in some places. You basically put braces on, wire the jaw shut. They can't eat solid meals. Some people might lose weight for a little bit with that, but, what's the problem with that, right? Well, eventually you have to take the braces off and unwire the jaws, hopefully, right? And so you haven't changed anything else. They'll go back to eating whatever they're eating before, and the weight will come back if they do lose anything in the first place. The other problem, and this is a problem with all restrictive techniques, is you can get past it. I mean, we're humans. We have blenders. We have sweet tea, right? We can get anything down we want to in liquid form. So if we go to high-calorie liquids, we can beat restriction, okay? Restriction's really got nothing on us. So it's hard to imagine how a restrictive operation is really going to work well, knowing what we know about the physiology. Now, there's also malabsorption. So this is the other way we thought, and this is actually how we kind of got into bariatrics kind of way back after the World Wars, was we had a lot of patients with short gut, and we saw that they lost weight. And so if we could artificially make short gut, then people would lose weight. Okay, well, one of the ways we did that back then was almost a whole intestinal bypass, the jejunal ileal bypass, and we saw a lot of problems with that, but they did lose weight. So we fast forward to now where there's procedures that we do like gastric bypass and duodenal switch, which were thought to cause a lot of malabsorption of those macronutrients and then weight loss. But we find out that with like a gastric bypass that we actually don't see any malabsorption. So basically 97% of the calories that somebody eats with a gastric bypass, they're absorbing, which is about what somebody who hasn't had surgery will absorb as well. Now there is some malabsorption for micronutrients, things like iron, the calcium, B12, and those kind of things. So I wouldn't say it's not malabsorptive for those things, but it doesn't work by that. And then one of the other problems with malabsorption is it's really just a restricted model, right? I mean, it's not being absorbed. The body's not sensing it. So it's almost like you never ate it. So the same mechanisms are in play that would cause you to be hungry when you're dieting as when you're restricting that way. Okay, so they would be limited that way if they didn't also have some of the metabolic changes that we see. And so we have some ways when we do the surgeries to actually change the metabolic response to eating a meal. And then, again, this is pretty much overly simplified, but again, the understanding is not that much more sophisticated than this right now. I mean, we can get into different forms of ghrelin and those kind of things and which ones seem to be correlated with hunger and which ones don't because it's made in different places in the body. But in essence, ghrelin, thought to be one of the putative hunger hormones, is made in the fundus of the stomach. And so if we can do something, either taking out a portion of the stomach like we do in a sleeve resection or we bypass the stomach, then we can decrease those levels of ghrelin and decrease the hunger drive. Now there's also satiety hormones, and this is kind of where the hindgut hypothesis comes from. So further down, the satiety hormones, by the time you get food down there, seems to be that the small bowel is seeing that you're bringing enough food down, you've got enough, obviously you've eaten, so now we can tell you to shut it off. We have hormones like GLP-1 and PYY that will feed back and decrease the hunger drive. And so we can bypass the bowel and empty things right into the distal small bowel and get those changes. Or in things like the sleeve, we'll actually see these go up because we got a decreased transit time. So things will get quicker down there as well. So all those changes there favor weight loss. The other neat thing that they do is, we talked about dieting a little bit earlier and what happens when you diet. Two things: you get hungry. Okay, so we've made some changes to help with that. And then you also get tired typically when you're dieting. So the metabolic rate ratchets down to save that energy. Well, in the metabolic surgeries, that metabolic rate is kept the same or elevated. Okay, so the changes that you see after surgery are almost the complete opposite that you see of dieting, meaning that you get less hungry, you still burn off calories at the same rate or better, and you actually lose weight, right? So some more mechanisms of that. We talked about a little bit about restriction. We should probably just strike through that one because we know it really doesn't work well that way. Malabsorption, altered gut hormones. There are some neural mechanisms we know. We know from the vagal stimulation that can help. Gut microbiota changes. I mean, that's been kind of a big topic. The poo pills didn't quite work out, but there's going to be more work to be done in that point. But it is hard to change your gut microbiota. Okay, it's hard to just take pills and change that because you already have an established flora. Altered thermogenesis, energy expenditures, and then the increased circulating bile acids are also associated with weight loss. The surgeries we do are laparoscopic again, and so these small incisions is a big advance over that big incision there. Okay, the hernia rates and the infection rates are 10 to 20% in those, and they're less than 1% in these. And you can imagine if you did have infection or a hernia in one of these, it's much less of a problem than these here. And then these patients also get up quicker. They get out of the hospital quicker. They just do better with the laparoscopic surgery. We do have robots that we use, and this is an XI model here. This is the latest model that we work with. And this is great. I think it's great for revisional, and again, for standard work, I think that it's the same as just laparoscopic. It's just a different way of controlling the instruments. It is a big step up from this robot here. I don't know if any of you guys know any Logan's Run fans out there. No? Nobody remembers that one? Yeah. All right. Too old. Got it. But Farrah Fawcett. Anybody? No? Okay. I saw one hand right there. Yeah. So, gastric bypass, we'll talk about that one first here so you can see what that one is. What we do, and we always talk about making this pouch out of the stomach. I really should just say we divide the stomach up here so we have something to sew to. There is not a goal of making a pouch that things can go in there and stay in there and then slowly get released. This is a straight conduit to the small bowel. Okay, that's the best way to think of it. The reason why we have some stomach here is so we can sew a little bit lower with less tension, and we have something that holds stitches better. Okay, if the esophagus would pull down a little further and it held stitches better, we would sew just to the esophagus. There's really no function of that stomach there other than those technical factors. It becomes conduit. And so there's not a restrictive method going on. Early on, maybe, and in the sense that you can't eat a big steak right away, maybe. But you could pour any liquid you wanted to down there if there weren't any other effects, right? Now, we know that when we bypass, this is usually about 100 centimeters, and this is usually about 50 centimeters, and that still leaves us with another 450, 550 centimeters or so of the small bowel, and that is plenty to absorb everything. Now, again, you're bypassing this part here, so you're going to have calcium, iron, some of these other issues, and the B12, doesn't meet up with intrinsic factor quite as well, and so you can have issues with those. But as far as the macronutrients, they're all going to be absorbed. So this doesn't work by malabsorption either. So it works by bypassing the stomach, decreasing those ghrelin levels, emptying food into the small bowel that was much further distal before, and increasing the satiety hormone levels. So the gastric sleeve resection came out back when it was mainly gastric bypass and gastric bands. And so it was the option where you didn't have to have a foreign body in as a band, and you didn't have to rearrange the anatomy. And originally with the surgeons too, it looked like something, well, everything goes through its normal route. We only have to worry about the vitamin issues and those kind of things. Well, we do know that we have to worry about vitamin issues because we know that we're not acidifying as much because we're taking out that fundus, and that things go through quicker through the bowel, and actually things get out of the stomach a little quicker. So again, it's not restrictive. Liquids will get through just fine, okay, but we've decreased the ghrelin by taking out a production center of it, and by getting things through the small bowel quicker, we get an increase in satiety hormones, and which was really exciting because it explained why we got much better, because remember at the time we thought it was restriction, much better than what we got with the band, okay, and almost as good as what we had with the bypass. A duodenal switch is kind of a combination of a bypass and a sleeve. First portion is the sleeve, where part of the stomach's taken out here, and so you can see the sleeve. And then in this case, we bypass a lot more small bowel. This is deceiving here. It's usually about 150 centimeters down here. But it is almost all the small bowel, and it's to the duodenum and not to the stomach. Okay, so we still have bypassed the early small bowel and a lot of the small bowel here. And we only have about 150 or so down here. So we do have some true malabsorption in this one. But again, this one works primarily through getting rid of ghrelin and increasing the satiety hormones as well. Now, interestingly, when this was done, they had a lot of patients. This is a lot of surgery. You can imagine leaving a duodenal stump and everything, that it can be a little bit more tricky and a little bit more dangerous for the patient. So they had patients that weren't great candidates to do all that, and so they did the sleeve resection first. And so we'll come back in 6 months or a year later and see if we need to do the rest of the procedure. And what they found was 6 months or a year later, they had lost enough weight they didn't need to do a second part of the procedure, and that's when they started just doing the sleeve portion, and that's where the sleeve became a primary operation. Adjustable gastric band at this point is almost presented for historical interest, and for those who have had to take care of bands, we're very happy to announce that it's mainly of historical interest at this point, although there's a lot of people out there with them still in there. It's basically a silicone band that sits around the top of the stomach, and you can inflate it to increase the restriction or decrease, or deflate it to decrease the restriction, and it's purely restrictive, really. I mean, there might be some neurofeedback there, and mainly in forms of nausea that decreases appetite some, but that's pretty much what the band was. And what we found out is, other than erosions and infections of the system and those kind of things, which actually are fairly rare, we're starting to see a lot of esophageal dilation and esophageal dysmotility, because it seems to be kind of a bad thing to wrap things around the bottom of the esophagus. And we've seen that before with an angel chick prosthesis that was used for reflux. We see this, which we were promised this was not the angel chick prosthesis, and we may see this in the future where there's a little ring of magnets that people are putting around the sphincter here now to help with reflux, and we may see that with that in the future too, because while it is supposed to not be the next lap band or the next angel chick, it kind of looks a lot like it, and the premise is kind of the same. So mortality of common surgeries, interestingly, if you look at mortality of common surgeries, and you know, I've been in bariatrics for a while, and I remember we did open bariatrics, and going from that and decreasing mortality and morbidity to laparoscopic was a big deal. And what's happened over the last 10, 15 years is you've limited the pool of people who are actually doing them and the places that are doing them, so you have people who are doing them all the time and don't just dabble in it, and centers that actually are equipped to take care of the patients. And so now we look at an overall mortality of about 0.1 to 0.3%. Okay. That stacks up well with about every other surgery that you can think of. If you want to get less, then you go to thyroid surgeries, you go to breast surgeries, you get less than that. But nothing's going to be zero for anybody, but really, I mean, right in there with everybody else, which I think is pretty good for what we do and who we're doing that with. Morbidity risks of common surgeries, again, right in there, okay? We're right in there with everybody else. Not picking on the cabbages. A lot of things that can go on after cabbages, and they can do fine, okay? But, you know, we're working on the heart there, right? But right in there, laparoscopic cholecystectomy, 5%. Bariatric surgery, 3%. For all intents and purposes, the same. We worry about leaks and blood clots, PEs, and those kind of things, right? They still have to worry about those as well. The interesting thing I was actually reading recently was the common bile duct injury rate still could be as high as 1.5%. And I don't know if you've ever managed common bile duct injuries, or somebody's had one or has to have the reconstruction for it. That's quite a big deal. And I would actually, you know, compare that to leaks with a sleeve or a bypass and say that a lot of times a leak with a sleeve or a bypass might be even easier to manage than those problems from the cholecystectomy. They can get pretty involved. So now if we want to take a look at surgery, okay, but something where we didn't take out or we didn't rearrange anything, we can look at the vagal blocking therapy, and this is almost like a pacemaker. It actually goes to the vagus nerves, and if you stimulate them enough, you can actually block them, and you'll decrease some stomach emptying, you'll decrease the receptive relaxation, you'll decrease some hunger, and people will lose weight. And things will work okay. The problem is the device itself costs about $15,000 to $18,000. Add on to that a surgeon's fee and a hospital fee and anesthesia fees, and you get a very expensive surgery. And so they weren't selling, so they're not commercially available now, which tells you two things. One, they couldn't sell them, and two, they probably need more work in the lab to show some efficacy before they can actually get insurance approval so they can actually get these out on the market. But neat device. I mean, it's really neat technology. There's the device itself. There's a little controller you can program it with, and this is actually the charging coil. And almost just like you charge your phones nowadays, you set it on the little charger there. You don't have to connect anything. Well, you just set the charging coil over the area of the skin where this is implanted, and you can charge that thing, okay? While you're doing other sedentary activities and stuff like that probably, right? So gastric balloon, not too hard to figure out how that one's going to work. Takes up some space in the stomach. You can imagine there can be a considerable amount of nausea with this. We learned on how to treat our nausea with some of our other patients by treating nausea with the gastric balloon. But it takes up space, and you know, you can't fit as much down. You feel the fullness. I mean, this is filled with saline, and it's about 20 ounces. So we put it in with the endoscope. There are some that you can swallow now and inflate. Just down in radiology, so you don't have to have balloons put in with the scope, but then at 6 months, you have to take them out. And that's kind of the key, is you have to take them out. So it's a temporary procedure. Okay, so unless you got that rare patient who really just needed a little something to get them by and get them started on dietary changes, lifestyle changes, and stuff, you are going to have a temporary effect, more than likely. But it could be 12% of total body weight at 6 months, and you can still see a little lingering effect after that before they start regaining weight. But that's a significant weight loss there. And it was indicated for BMI of 30 to 40. So one thing it did give us was a modality to treat people who are at a lower BMI than we traditionally would treat. And here, just showing you here, compared to some other items here that you can see about the size of it. I tell patients like a grapefruit, and if you want to know how it feels, you know, try to swallow the grapefruit whole. Let that sit in your stomach for a while. It's probably how it feels. At least that's how it's described to us from the patients. So again, it's restrictive, but the biggest problem is you're going to have to take it out at some point. So our enthusiasm here was initially not so great, and now it's kind of just stayed not so great. We've had some patients do pretty well with it. We've managed some patients who taught us a lot about nausea, so we don't do a whole lot of those. I think you have to be a better salesman to do those. And the problem is, too, you look at effectiveness of the obesity treatments here. If we look at the percentage weight loss in the Swedish obesity subjects trial, and they have some of the longest long-term data out there. If we look at here, we see the gastric bypass, and we see a typical weight loss curve, which is over the first year or two. You see weight loss, you see a little bit of weight regain, and then a leveling off. Compared that to banding, but then, unfortunately, compared to the lifestyle and medications we saw, we were fairly dismal here. We haven't really moved this one very much, but we saw very effective weight loss. Okay, I guess I kept this one in here. I thought I had taken it out. But this is just an interesting curve. I was able to pull off our old system. This is a patient that had their surgery up in Nashville, had a good gastric bypass, actually had lost a considerable amount of weight and then had regained weight after that. And we had worked with her for a while. Even at this weight, was still 100 pounds down from her initial weight, so wouldn't consider a failure by any means, but she certainly had a lot more room to improve. And we did what we call distalizing the bypass. We bypassed more. And so thinking we'll get a higher effect from the hormonal stimulation, then she lost weight, and then she got pregnant, and then she gained weight. Okay? And the interesting thing is after pregnancy, she immediately came down. And she didn't come down to where she was before. She came down to where she would have been if you had followed this curve out. Okay, so we had basically changed where her set point was for the weight. And even though she had sort of artificially, sort of physiologically increased it for a period of time, once that was over, then she was back down to her set point. Average weight loss with procedures, just to compare the weight losses. Gastric bypass here, sleeve, band, switch. You can see here, if you want total body weights, I got them here on the left, and excess body weights here on the right. A lot of contention about which is better. Of course, surgeons, we like the bigger numbers. 65% excess body weight sounds better than just losing 25% of your weight, right? Even though we know they're the same. So you'll see a lot of surgical literature talking about this, a lot of medical literature talking about this, and it will kind of go back and forth some. But you can see the bypass and the sleeve are very close. And then the band is kind of down here at 35. That's fine if it wasn't for the other problems with the band. We'd still be doing it because you do get a significant weight loss out of it. Duodenal Switch, a little bit better, but there's not huge disparity between the sleeve, the bypass, and the switch when it comes to the weight loss. So that's not a big discriminator on what we use there. And then the vagal blocking, you actually see significant numbers out of that, and the gastric balloon. Again, those are short-term numbers. Those vagal blocking numbers at a year and a half. I use this every time I talk to my patients, and I show them this graph. Dr. Kaplan was nice because he had this nice graph to share that with me and let me use that. But if you look at the average here on these gastric bypass results, about 65%. So that's the average. And so I do this point out that there are patients out here who lose all their excess weight, but I show the patients this as these are the patients right here. These few patients lost all their weight. So that is not the expectation from surgery that you lose all your weight. We would be surprised if that happened, right, because it's very few. Now, to gain it all back, it's also few and far between. Okay, but the patient wants to know how much weight am I going to lose after the surgery. My first answer is always very honest, and I don't know. I don't have good predictors of that. I do know where the mean is, and I see all the people within a standard deviation of the mean, and I know it's going to be very well, most of the time for them. In fact, if it's 80% of the time, they're going to lose at least half their extra weight. And you can see here, 50% lines here. The people don't get 50% off are mostly between 40 and 50%. So they're most likely going to have a very good weight loss. But if they were expecting to lose it all, they're going to be disappointed. Okay. So what's happened over the years with the bariatric surgery trends, the old vertical banded gastroplasty, which hopefully nobody has to look at here, pretty much kind of done and gone by the time we got to the year 2000. I see some people have had them in there. We convert them to other things, but they did not do very well. Most of those there's a partitioning of the stomach that is done, and that partitioning opened up. Body's amazing, and it will overcome anything, and they have gained their weight back, and I'll see them, and usually they'll get a bypass. But bypass kind of reigned supreme for a while, and then the band came in, and the band shot up, okay, not almost the same as what we see with the sleeve here, and of course, by virtue of that, the bypass came down, so they were done about almost equal numbers. And then, as the band decreased in popularity, sleeve was still new, so a little bit of resurgence of the bypass, and then now we're getting kind of a crossing of the lines where the sleeve is taken over. And in strict terms of numbers, you can see that here is almost 60% of the surgeries we do now as a primary operation are sleeves. Bypass is only about 17, 18% here. Bands are down to 2.7% here. Very few. There's a few hangers-on out there. Duodenal switch, still fairly rare. Revisions, and I will tell you, most of these revisions are bands to either bypasses or sleeves to bypasses. And then other operations, some of those other operations we talked about, and then a few balloons being done out there as well. A lot of different quality improvement projects, and we follow our numbers out there pretty tightly for our accreditations. Finally, we don't give up on all these other things we talked about once we've done surgery. It's not the end of the line. We still work on eating, exercise habits, and we still will use medications to either maintain the weight loss or make the weight loss a little bit better. Talk about sandwich therapy. Here's a patient here who had a very good weight loss and had their nadir down here, looked really good, started gaining weight. We're a little worried about that with them. They didn't feel like they had as much control. And I think this particular patient was started on Wellbutrin and naltrexone combination, and we saw a decrease back in the weight to a little bit lower point here, where it's a little bit more satisfying for the patient there. So we like, if we're going to do it, we like to follow them close and try to intervene when they're down here, rather than if they're wanting to gain weight, then try it up here. It seems to work a little bit better. Who do we operate on? Consensus statement really hasn't changed much, but there are a few notable changes. BMI 35 to 40 with comorbidities, and 40 and above on its own would usually qualify for surgery, and that holds for most insurances. Exceptions 30 to 40 with balloons. With the vagal blocking, again, kind of a moot point now, but 35 to 45 would have worked. And then they have to have had failed previous attempts. We don't want the surgery to be the first time they've ever tried to lose weight. And then they have to be a good surgical candidate. And I always throw in there my editorial of whatever that means, right? I mean, it's really kind of hard to tell sometimes if somebody's a good surgical candidate on a variety of different factors. Algorithm for surgery for diabetes. So interestingly, we're not operating just for morbid obesity anymore. People are looking at operating for type 2 diabetes, almost irrespective of morbid obesity, because what you see here is the algorithm now includes people with a BMI of 30 and above. And if we're not able to control them there with lifestyle medical therapies, and we can't control them real well, we start considering metabolic surgery there. So what you're seeing, and the trend will be, is a downshift, because as things have become safer, we've shown they've been very effective and more effective than the medications we have right now. We see bigger consideration of metabolic surgery for that. Okay, so some challenges we have. Smokers are one of the biggest challenges. They really throw a wrench in the works. Obviously, they don't heal as well. They don't do as well overall. They have a lot more complications, so we like to get people to quit smoking. Smokings are associated with ulcers after bypasses, especially, so we like to not do bypasses with smokers. In fact, we'll make a smoker quit for at least 6 months before we would consider doing a bypass on them because of that. So the sleeve would probably be better with a smoker. Specific medication requirements. If they're transplant patients, we know they're going to be getting a lot of high-dose steroids afterwards. Sleeve might be better because it's a little bit more resistant to ulceration than the bypass. What if they're on NSAIDs and they can't give up their NSAIDs? They're dependent on those. Again, sleeve would probably be better for them. Advanced age. How old is too old? Okay, I don't know if we really know that. I think the oldest we've done here was 79. And it's still hard for me to say that sometimes, but both of her parents lived into their mid-90s. So, I mean, she was a selected 79-year-old, but I think you have to consider those things and consider how long they're going to have to live with their disease, because there's a quality of life component to it. Advanced medical illnesses, I mean, at some point there probably is such a thing as end-stage obesity, okay, where the chance of us really hurting them, okay, or even ending their life with the surgery may be higher than us actually helping them. And so there's probably such a thing as end-stage obesity. And then, we have risk stratification in our databases, but it's not really that strong, okay, meaning that you have a lot of us out here are going to be a little risk averse because what that'll do to a program if you take on that risk and you get burnt, okay. So sometimes a single complication can ruin your accreditation for a year or two. So you do have to be a little careful as a program when you're selecting your patients. There are some nice calculators out there and algorithms for choosing whether you do a gastric bypass or a gastric sleeve, and Dr. Amenian at Cleveland Clinic was good enough to come up with this and actually put it into an app form, which is great. And basically his point here comes down to when you have severe diabetes that neither one, if it's been long-standing severe, neither bypass or sleeve is likely to result in neither one's better at resulting in full remission. Okay, and that's great to know that, but improvement counts as well, because if you can get somebody off insulin, and even if that's all you did, that would be a huge deal for that patient. But the only problem I have with this really is that it only takes into account the diabetes when selecting, and there's actually a lot of other things involved in it. Let's say the reflux. Okay, reflux is the Achilles heel of the sleeve. And probably the reason why we'll be converting a lot of sleeves to bypasses in the future is because of the reflux. So people with bad reflux already, big hiatal hernias, much better to do a bypass with them. Diabetes, the bypass does tend to be better for diabetes. Again, in some cases, there may not be much of a difference between the two. If you have to take your NSAIDs, you're stuck on your steroids, the sleeve would probably be better. High BMI, we tend to think about the bypass, but it's probably not as much of a big difference between the two in terms of weight loss. And smokers definitely would rather do a sleeve than a bypass with them. If you look at invasiveness of therapy and then the relative weight loss, what you see is the trend is the more invasive you get, the better weight loss you get. We haven't quite kind of pushed anything to find something that's not invasive that gives us the same as the more invasive techniques. Hopefully, I was able to impress on you that even though these are invasive, compared to other surgeries that we order all the time, gallbladder surgeries, hysterectomies, and things like that, very comparable in their risk to those. And a reminder that, even though we've kind of stuck on surgery for a while here, and we didn't hit pharmacotherapy, different talk for a different time, or lifestyle modifications, again, could be a whole different talk, different time. It's all built on that, okay? And that goes up and down and sideways, that we're always working on lifestyle modifications. We always use pharmacy and then the surgery procedures, and it's not necessarily always a linear way of getting there. So just to kind of sum it all up, obesity is the disease. I'm okay if you want to say obesity is a marker of a disease. I don't care as long as we treat the disease. Got to make the medications and interventions part of your armamentarium. I would, really urge you, because I know we don't have a lot of obesity specialists out there, to go and do the extra work, do the learning, and don't let the obesity specialists take this and put it in small centers to take care of the obese patients, okay, the patients affected by obesity. All right, because what that's going to do is going to limit access for those patients when you guys are the ones that see them all the time. So it makes much more sense to keep that in the primary care clinics. You got to set realistic goals and realistic timetables. We talked a little bit about that. And the interventions are most effective when you apply them early in the course of the disease. Okay, so not waiting until they've spun their wheels for 10 or 20 years trying to lose weight, and while they collect problems with their diabetes and everything else, and then their heart gets worse, and then we see them when they're a little bit higher of a risk. If start early, and if we find things aren't working, then we kind of move on to other things. And then I did not, because I usually get criticized for this, I didn't say diet and exercise aren't important, okay? We haven't spent much time on that, and they are important. We talked about healthy muscle driving things and stuff like that, and changing the diet certainly are, okay, but they are just not enough if that's what we stick with, okay? So kind of we scratch the surface on a lot, but if you have questions, I'll try and answer them for you. If you got other topics you'd like to talk about some other time, I can either come back or I can have somebody else come back and talk about those for you too. Yeah. Right. So for both of them, typically they go home the next day. And here that's the next afternoon. That gives our bariatric nurse time to go talk with them and really give them information they've had before. They're just much more receptive to it after they had the surgery, right? The eyes are even a little wider open there, and we just kind of make sure they've got their teaching and everything before they go home. But most will go home the day after. Few will stay a second day. I think looking at our last report, our average length of stay was about 1.4. So it's a short length. Going back to work for both of them, typically if it's a desk job, it's a week or two. The heavy lifting or straining like anything else would be 4 to 6 weeks. And the good thing is, you asked about sleeve and a bypass, there's really not much difference other than the surgery itself in how they're handled, how they're treated afterwards either. All right. Well, I appreciate you coming out and listening. So, and I appreciate the ice hanging off this morning too.